Thank you, Mr. Chairman, for holding this hearing. I want to thank the witnesses as well for traveling to be with us here today. You know, it is exciting to hear some of the things that are happening in the medical field. We're going to see, I think, big changes in the way that care is delivered. Patients will be experiencing better care over the next years and decades, and better care in rural and underserved communities as well. So it's really exciting. We're talking telehealth, remote patient monitoring, home dialysis, home infusion. These all have sort of reached, in some way, the mainstream. They're cost-effective ways to deliver quality care to patients right in the comfort of their home. It reminds me, I served in the state Senate in Pennsylvania prior to serving here, and we were talking a lot at that time about changing the system to allow folks to age in their homes. And what we found was there were a lot of sort of regulations. There were funding reimbursement methods that prevented quick movement and allowing people to age in their homes as they wanted to do. We found there was better outcomes. It's what elderly folks wanted, and actually it turned out to be less cost as well. So it's like it was win-win-win, but it was very hard to move to that because of regulations that were in place and so on. So, Ms. Maddox, you mentioned the lack of innovation. I don't know that I'll even have a question here, but you mentioned the lack of innovation in the dialysis space, and I wonder at times whether that is if it's a funding, if it's the regulations that are in place, and I think the answer is probably yes. And so what we ought to be thinking about is how we can sort of unleash that innovation and encourage and incentivize that innovation. And I think we'll get a lot of data. If I do get time for a question, maybe Dr. Starr, I'll ask you. I would be interested in what data that we have available now about the improvement in the quality of care under some of these home health care things. But before I do that, because I may run out of time, I want to talk just briefly about a bill that I've introduced with Mr. Doggett, another member of the committee, called the Medicare Home Health Accessibility Act, which is related to some of the things that we're talking about today. This bill would establish occupational therapy as a qualified Medicare home health benefit. Currently, a Medicare beneficiary can't receive OT services in their home unless there's also nursing, physical therapy, or speech services at the same time. And this bill would change that. So again, one of these regulations that I think is preventing better care. So this would ensure that seniors with conditions like low vision, dementia, diabetes, and other conditions, instead of having to travel, will be able to receive that care that helps them safely manage activities of daily living and thrive in their homes. And studies have indicated that OT services like this will create savings for the Medicare system by preventing falls and other accidents that too often lead to emergency room visits and maybe even hospitalizations. So again, with this bill, we want to ensure that the care that patients experience in an acute care setting is also available to them right at home, which is what many of you are doing as well. And so I appreciate the work of Mr. Doggett. We've co-sponsored this bill together and hope that we can see that pass. But so, Dr. Starr, I don't have a lot of time left, but I do. Can you build a little bit of what I mentioned and describe what we're seeing in terms of patient outcomes across the board? Are they equivalent at this point? Are they? And I know we're early on in some of these things, but are they better? Are the outcomes better when patients receive services like hospital at home or other treatments in their own homes rather than in a facility?
Yeah, thanks for that question. So the data is still young, but what is emerging is that it is at least as good, leaning towards better in many of the outcomes. I think many programs have shown a decrease in readmission, 30-day readmission to being treated at home. There's definitely a reduction in infections like nosocomial infections because you're not around those dangerous bacteria. I think one of the really encouraging things is we also have seen it's not dangerous to be treated with hospital at home. We're not seeing bad outcomes for patient being treated, and it is a safe model in that sense.
Sure, and I think as we go along on this, we'll get more and more studies, so that'd be good here. We certainly know, I think Mr. Underhill, You talked about it, Ms. Maddox, the difference that's made in your lives to be able to receive care in the home. So appreciate both of you, all of you, for sharing your stories and being here with us today. Thank you.